All right, so it's about that time. I'm just going to go ahead and give it a few more minutes for a couple more people to hop in. I see kind of view count popping up there, so give it just one more minute. All right, well, welcome everybody to the case study breakdown. I hope everybody was able to watch the preview and kind of start getting that brain juices going, what you thought was going on with that patient with the difficulty in breathing at the nursing home. So let's get into it. So to review, you were dispatched to that local nursing home, 74-year-old female having some difficulty in breathing. You found her laying in bed. She was already on some, supplemental oxygen with cannula, and the medical staff at the nursing facility was attending to her. They're telling you that, the shortness of breath was going on for 2 days, and they've tried giving her, her meter dose inhaler, tried nebulized medications as they normally do, and it just doesn't seem to be breaking at this time, and they don't know what's going on. So did you find her airway is patent. She does have some mild labor breathing. Skin is dry, but does have some cyanosis to the lips. For disabilities, none was really noted. She does have a little bit of an ultramental status. for us, but for her, that is her baseline. Okay, so remember that being something abnormal is subjective to us, but that is her normal. And then environmentally, you just see that she's on that nasal cannula at 3 liters. As you start asking more questions, assessing a little bit deeper, you start seeing that um, she'd been coughing up some pink, frothy sputum. You notice that from some tissues in the trash can and just what the medical staff had told you. They're also telling you that it seems like it's been worse at nighttime. That when she goes to lay down at nighttime, it seems like that cough and shortness of breath just really seems to exacerbate itself and just getting really short of breath at nighttime. For the past medical history, what they give you and what you find in her demographics, history of hypertension, COPD, CHF, and coronary artery disease. Given a quick assessment, you notice some upon auscultation, wheezing in the upper lobes, had some rails in the bases. Her abdomen was soft, pliable, is symmetric, is non-tender. Rest of the GI is unremarkable. Once you got her out in the ambulance, put her on the monitor, heart rate varying 70s to 80s. Looks like atrial fibrillation, just at irregular rate. 86% on that 3 liters. And you got blood pressure of 138 over 86. With that, you got a respiratory count of 25 and blood glucose marginally hyperglycemic. Did just recently eat. So the questions I posed to you was, what would be your differential diagnosis or diagnoses? What other type of assessments would you want to do with this patient? And given each of those differential diagnosis of what would be your treatment plan? So for each one it came up with, if it was this, what would you do? All right, so coming up with that differential diagnosis, you start putting all those things in your head about what could be the culprit behind this. Given her history, the presentation, everything, just what starts going in your head. All right, so we start thinking about, well, COPD. Okay, that's, let me give a marker back out. Okay, so we started thinking, well, maybe COPD. Well, it does have a history of COPD. Was wheezing. So it starts kind of going down that baseline. But then having that other associated history of, congestive heart failure, hypertension, and whatnot, but then also presents with rails in the bases. So we kind of keep this in our mind that maybe it is COPD with that too, causing that bronchospasming and that wheezing. But COPD is not going by itself, is not going to create rails or fluid shifting into the lungs. So kind of come back to that. What about a pulmonary embolism? Well, generally, pulmonary embolism in the acute onset is going to have clear lung sounds because it is a perfusion issue, not a ventilation or respiration issue. But yeah, so presented hypoxic, but having that bronchospasming and the rails and hypoxia, and with that, yeah, we kind of go away from that. So the rails can come in long down the road with that PE, but it's generally going to develop into like pneumonia, infections, having fevers and whatnot. And patient in this one is afebrile, um, and kind of lung abnormalities on both sides. So we kind of go away from that one. MI, definitely can't rule that out right now. So we know if anytime that cardiac tissue becomes damaged, that's going to hinder our ability to perfuse and have cellular respirations. So can't quite completely rule that out, but patient was asymptomatic to every other type of acute coronary syndrome. There was no chest pain involved. Um, in the demographics, the AFib was normal. That's a controlled rate. So we're not thinking a crazy dysrhythmia at a rate of 70, 80, variably controlled. We didn't notice any type of ectopy in there or whatnot. So we're going to kind of marginally cross that out as well. And then we started thinking about anemia. Okay, so anemia, if there's just not enough blood cells for all that oxygen to hop onto. So this could very much be seen and present that way. The only difference being is that pulse ox is going to be falsely high. So every blood cell that pulse ox would evaluate might be 98% saturated, but there's just not enough to continually circulate. So if you're seeing that, very short of breath, cyanosis, but the pulse ox reading falsely high, we would lead towards that. But no history of anything related to that. So we can kind of start ruling that out with no history, pulse oximetry being truly hypoxic, adventitious breath sounds. Definitely kind of going away from that. And then the big one to the end is CHF, because we always associate congestive heart failure with fluid retention, whether we're building that up in our lungs, into our extremities, into our feet for pedal edema, extremities in the abdomen, ascites is that fluid buildup in that abdomen area. So we kind of start going that way. And yep, that's kind of our gold ticket of where we want to go with what our true field diagnosis is congestive heart failure. So, all right, we get these marks off here. All right, so what is congestive heart failure? Well, if we look at what our typical heart is, we've got the left ventricle over here is just a little bit thicker than the right one, because the right one, its only job is just to shove some blood in the lungs. Doesn't really have to push real hard. The left ventricle responsible for complete, systemic circulation. So it's got to have much larger muscles to shove that the blood everywhere. So we'll have, much stronger muscles in that myocardium there. When a congestive heart, what you're going to start to see is expanded or dilated ventricles. And we think about what's really causing that is, generally pressure build up back into here. So that pressure has been pushed against that left ventricle coming back in as it's trying to push out. So it's going to eventually cause that muscle in the myocardium to become stretched out and can get to that point that's beyond its point of elasticity, as we would say. So imagine that rubber band is pulling, 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 nice and springy. But then you start pulling it and pulling it and pulling it, and it gets really stretchy and it loses a lot of that snap. So that left ventricle in this scenario is going to be that same way of that ventricle just becoming very dilated from being overfilled, overstretched, and losing a lot of its elasticity. And the whole fact of Stirling's law kind of goes out. So Stirling's law relates to the amount of force that goes in, relates to the amount of force coming out, as long as things are in play. But with this, the myocardium becomes damaged, becomes stretched out. So you can see here, big, strong muscles over here, really thinned out. The ventricles are dipping down, kind of getting pinpoint into the bases, and that's causing that congestion. So the main causes of congestive heart failure is going to be coronary artery disease. So all the vessels around the heart, the heart just doesn't perfuse, so that myocardium starts to die because it's not getting enough blood flow, enough oxygenation. So over time, that begins to die. Or if it was just acute onset of myocardium death, like as a myocardial infarction, that coronary artery disease got so bad that it suddenly infarcted that tissue, and now that tissue is dead. So imagine if that infarct was in the left part of the heart, and now instead of it just being prolonged over time, that left ventricle stretching, 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 you took a rubber band, you cut just a little snip in it. It still stretches a little bit, but not nearly as much as it used to. So just dead tissue. Chronic kidney disease of causing, overcongestion. The kidneys and liver and whatnot, they're not able to filter out as much as they usually do or what they should be able to do, as well as chronic kidney disease. We know that our kidneys regulate our blood pressure. So if the kidneys are failing, we're having unregulated hypertension, and that's going to further prolong that the pressure buildup inside those ventricles and making them wear out. Diabetes, just bad blood, bad circulation everywhere, so it's just bad for all tissues. So that kind of goes into effect of hurting the kidneys, then the kidneys hurt the blood pressure, and the blood pressure hurts the heart. Cardiomyopathy, if you basically just something has happened over time to injure that myocardial tissue, whether that is even something as genetics, viruses, pericarditis, something has caused the actual heart tissue just to become damaged that's kind of outside of these. And the symptoms we're going to see. So in congestive heart failure, we're going to see that fluid buildup, whether it's pulmonary edema, peripheral edema, hands, feet, lungs, abdomen. We're going to start to see edema happen because those blood vessels start to become slightly leaky, and the fluid that's built up in them is going to start seeping out in that capillary bed. Shortness of breath on exertion. So as they begin to do anything, their heart can't keep up with the amount of stroke volume that's needed because they can't push it out. So the cardiac output decreases, not enough blood getting to the lungs, and so on. So that kind of backtracking effect of heart's trying to work, the cardiac output can't keep up because of the reduction in stroke volume from those worn out, tired, overworked ventricles. And the proximal nocturnal dyspnea. Basically, at nighttime, you get shorter breath. Okay. And orthopnea. That means that, classic in this scenario of the patient's laying down at night, makes it harder to breathe, and at nighttime. Okay, so imagine that if you have your lung and then the fluid on the bottom there. Okay, so minor surface area. Now you take that and you tilt your lung on the side. Well, now that fluid lays on your back as you're laying down at night. So one thing that could help immediately with these patients is get them to sit upright. So in that way, only the bottom part of their lung is actually having issues, whereas this, we're covering fluid with an entire, not entire, but a large surface of that fluid shifting out through alveoli, and it's going to reduce our ability to have cellular respirations. And then other things we're going to start to see is weight gain because one, your body becomes fatigued. You're not nearly as active as you once were. So you start to develop all this things. Your metabolism gets reduced from overall poor circulation, and you just have chronic fatigue. Building up further, what we're going to see is, there can either right side or left side of heart failure in congestive heart failure. And what that means is there's a backup. Okay, so the way that I've like to explain this is imagine the ventricles are that cashier at a really busy shopping day. Say, Black Friday, you're at a retail store, the person's working register, just 90 years old, trying to make some extra Christmas money, just beep, how you doing? Beep. They're tired. They don't work really fast. So what happens to their line? Their line gets extremely backed up. Well, that's what's going to be going on here. Okay, so that right ventricle, say, if it's right-sided heart failure, then it's going to be backed up from that right side. So blood from the right side returns from the body. So if it's backed up, the furthest part from our body is where you're going to really start to see it back up first. That's going to be in our feet. So they're going to be right-sided heart failure is going to develop that pedal edema. You'll start to see their feet tissue just looking cyanotic all the time because it's bad blood down there, swollen feet, just looking like the skin is essentially dying because it is. There's very, very poor circulation down there. Whereas in the left side, it backs up again. So everything comes into the left side from the lungs. So if it backs up, that fluid starts to seep into the lungs. All right, so remember, our fluid's going to shift depending on which side of that heart has failed. Now, they could be, an extensive, like late stage congestive heart failure to where both sides have failed. Because we would know that if the left side has eventually backed up, that's going to make it harder for the right side to be sending blood to the left side. So as that left side would start to fail, it's going to be a backtrack into the lungs. It's going to cause that pressure all the way through the lungs back into the right ventricle. Okay, so that line just continually backs up, backs up, backs up. So, you can imagine blood's coming, from here down to here, through the lungs, then back into here. Well, as that line starts to back up, that's where you're going to start to notice more and more and more and more and more congestion. Eventually, where it's going to cause all that strain there. So, in that right-sided heart failure, so this would be our muscle tissue, say, in our feet, because that's where you're going to generally see that fluid build up first. Okay. So, if you have the leaky capillary beds, it's going to start seeping into that muscle and tissue at the furthest extremities. So, from that pressure just being built up, you're going to have a higher pressure in your vessels than you are into the tissue. It's going to start to make this stuff kind of almost like dry rotted. So, imagine like a garden hose that's laid out in the summer sun forever, and you get a lot of pressure on it, just starts little pinholes start popping out. Well, that's what's going to start happening here. Having a high vascular pressure, going to start seeping fluid out. Okay. Uh, would you see modeling in the feet with the edema? You very well could. So we'll see modeling a lot of times, and when tissue becomes kind of infected. So you can. I mean, if you have cellulitis can occur. So with cellulitis, is that reddening, that different color tinting to the feet. So you definitely could. One of the first things you're going to see is just that swollenness, and then we'll have that pitting pedal edema. So that means if this was a tissue, you touch it a little bit and it doesn't really do much, it rebounds pretty well. That's really kind of non-pitting. And then we've got multiple levels of pitting pedal edema, and that just depends on, excuse me, whenever you push in, how much of an indentation that makes and how long it takes for it to refill. These patients, you could go and look at them and they could have just taken their socks or their shoes off and it still has that form of the sock around. So a lot of times with them, they're going to wear those socks that are not really tight and binding because it'll just create like a little mushroom top on top where their socks are or their shoes. Okay, so now right side, fluids shifting out of the vascular space into the muscle space, causing it to swell. Now, in the left side, that's where we're going to really start to see that pulmonary edema. Okay, so it leaks out of the capillary beds, and those capillary beds are attached to the alveoli. So that's where they're going to leak and get into here. So then as it builds up, it's actually just going to fill from the bottom up. Simply like if you're not what you think it's quite this directly, they're just continually puddles of there that you make the lung into a complete pool, but we know that it's going to start down here and it's going to build up as we go. All right, so fluid shifts into here, and because of the over high pressure at that alveoli, so the pressure in the vessels is greater than the pressure that's within that alveoli. And so keep that in mind, that fluid is coming into the alveoli because of pressure in the vascular system is higher than the pressure gradient between the alveolar membrane and that capillary bed. So treating CHF it's all about pressure. So that's what our treatment timeline is going to be aimed at. First and foremost, oxygenation. Any patient who's short of breath, we're going to be giving them oxygen. And that's going to depend on their work of breathing. So like in this patient that was already on nasal cannula, having labor breathing, immediately we should be putting them on high flow oxygenation. Really quick, that's our primary assessment of airway, breathing, circulation. We found airway was patent, breathing there was an issue, quick timeout, intervene, give high flow oxygen because they're labored, they have cyanosis, then continue on. So we've treated with high flow oxygen, and then our next step is going to be pressure. So CPAP, continuous positive airway pressure. Because again, like I said, the treatment for this is all about pressure. And then we're going to go into nitrates. The nitrates are going to help us with the pressure, which we'll hit here in just a second. And then further down the timeline, okay, so think about in a timeline of how quick all these work. So oxygenation, boom, we can give supplemental oxygen very quickly. CPAP, pretty quick to set up, almost immediate effect. As soon as it's on, there's an effect happening. Nitroglycerin, when you're using this in supplement with CPAP, we know that giving nitro to our typical ACS patients, onset's pretty quick. Within a couple minutes is when nitro starts to kick in. And then furosemide. Furosemide's been a main staple as a loop diuretic for a very long time. However, in research now, it's beginning to have some controversy in there. And then think about where we're at. Yes, they're probably going to need some type of diuretic eventually. But if we think back about how, chronic kidney disease can cause all these symptoms, if there's complications with their kidneys, we're not going to be able to have diuresis, and Lasix have the kidneys take that effect to cause internal diuresis to get rid of the fluid. So if the kidneys are not working properly, Lasix is not going to help nor work and could actually cause more harm. So in the hospital setting, the overwhelming majority of the time now, they're doing kidney function exams on these patients before they start Lasix. And it used to be taught, we'll just give them Lasix immediately. But we think about the onset of furosemide is like 45 minutes. So you're quite into your care before this even takes effect. So, and then with that, at the hospital, they feel like they have that time. It's like, well, the medicine takes 45 minutes anyways. Let's go ahead and take this exam because this is going to be, a longer, prolonged intervention and treatment with this. Okay, so and knowing that these patients, they may already be taking Lasix regularly, but again, if they have kidney disorders or they're not working well, or they've got some type of metabolism impairment, the Lasix that they're on may not be working. So giving them more may not be the answer. And again, this is an onset of like 45 minutes. So we don't want our patient to be in significant respiratory distress for 45 minutes before anything really starts to happen. So quick onset, pretty quick onset, longer period of time. All right, now moving on into the treatment, with oxygen and CPAP, what we're doing is we're trying to increase, peak pressure basically. Okay, so by increasing the peak pressure, we're giving more surface area for that alveoli to stretch out. So by creating more peak pressure, alveoli stretches, and now there's more room for oxygen and CO2 to do gas exchange, as well as it's now creating a higher level of pressure within that alveoli, and it's fighting against that high pressure system in the vascular system. So it's very much like a push and shove match. So fluid shifted in because the vascular system was pushing, well, then we put them on CPAP to help push back. So we're increasing alveolar peak pressure, creating more surface area for all that gas exchange to happen. Okay, so then that's when we throw in the nitroglycerin. So think about this though. A contraindication for CPAP is, pretty significant hypotension. So, we got to get the vital signs in and whatnot first because this will increase intrathoracic pressure, puts a little bit more strain on the heart, which can have a tendency to drop the blood pressure some. So, if they're already hypotensive, we're not wanting to go CPAP. And knowing that this can drop the blood pressure a little bit, we want to give them some time to get used to that CPAP, say, 3 to 5 minutes for everything to kind of balance out, repeat our vital signs to make sure our blood pressure hasn't dropped significantly to where if we give them nitro, it's going to do more harm than it would good, further worsening their hypotension. And then how this is going to help us is, like I said, increasing the pressure on the lung side. Now this is reducing pressure on the vascular side. So again, it's just a push and shove match. So vascular system pushing, CPAP pushes back, and then a nitro kind of comes in, gets behind the knees, and you tilt them over. All right, so nitro goes in, causes that vasodilation, reduces that pressure, and then also, now that the pressure is increased here and higher, it gives space in here. So we kind of open up this container. So we give more space for all that fluid that's in the alveoli to seep its way back into the vascular system. All right. So again, the big thing we're going to be looking at is treating them aggressively at the airway management. So quick oxygenation, get as much oxygen into them as they can, because if there's alveoli are full of fluid, that cellular respiration is not happening. And then we're going to be going to CPAP. So starting out at about 5 centimeters of water, 3 to 5, depending on what your local protocols are and what device you're using. So given that peak pressure, stretch out the alveoli, let them get acclimated, reassess. A couple little personal things that will really help is with CPAP. If they've never had that on before, make it a subtle thing. So start out easy, of maybe putting the mask on and you just hold it, or coach them to let them hold it before you're trying to, slam a mask on their face and stretch a cord around their head or buckle it down. That can further induce the anxiety they're already experiencing from the respiratory distress. So start out easy, support the mask, secure it, and then reassess, then give your nitrates, and then again, the Lasix is going to be further down the road. And something else we can think of too is, if they're incredibly anxious from that CPAP being on, is giving them a type of set of some mild benzo. But be mindful of that benzos have a hemodynamic effect, so we don't want to be plummeting their blood pressure in these issues. All right. Uh, Research has shown that morphine used to be a main staple too, because it was a vasodilator, that would help too, and it would help with their anxiety. But the newest research is saying that it really does no good. That the primary pre-hospital treatment for congestive heart failure exacerbations with pulmonary edema is oxygen, CPAP, and nitrates. So thanks everybody for tuning in. I hope a lot of that kind of made sense and put some pieces together for you. So I'll see you guys out on the next one. Oh, Melissa, saw your comment on there about 12 lead before CPAP. Not necessarily required, because if they're having respiratory stress, we want to treat that before we're worried about the diagnosis. So CPAP, then throw that 12 lead on to kind of see where you need to go after you got that airway stabilized. Thanks everybody for tuning in. Thanks for those who put in the comments, and see you guys out the next time.